In the next 4 slides, we are going to see some specimens of the liver which are normal and affected by fatty liver, along with the histological picture side by side. In this you see the normal liver, very smooth, glistening, nice left lobe of the liver, the right lobe of the liver. Normal liver weighs around 1200 to 1400 grams. Here this is an histological picture of a normal liver, hepatocytes, Kupffer cells, stellate cells and endothelial cells. There is no evidence of fat or fat globulation and vacuolization of the cells, and everything looks perfectly normal. Now, let us see steatosis or fat deposition in the liver in the next slide. This slide shows the fatty liver. Look at the altered color of the liver. The red looking liver has turned orange red or yellowish because of the deposition of fat. It is enlarged compared to the normal liver. Even the right lobe shows much enlargement due to the fat deposition. Your liver architecture histologically is replaced. Hepatocytes show accumulation of fat within each of the hepatocytes. So much so, the hepatocyte function is compromised, the transaminases are elevated, alkaline phosphatase is elevated, gamma glutamyl transpeptidase is elevated, and SGOT SGPT ratio is still maintained at less than 1. This is a case of fatty liver or simple steatosis, which is also called NAFLD. The next stage will be with inflammation and fibrosis producing NASH. Now, this is a slide of steatohepatitis. That means not only there is deposition of the fat, there is inflammation, inflammatory markers, inflammatory reaction, which will end up in some amount of fibrosis, and this is termed NASH or NASH, non-alcoholic steatohepatitis. Look at the inflamed liver. As you see a skin inflammation, the liver inflammation shows pedicle red dots all over the liver. Liver, of course, is enlarged and weighs around 2220 grams. Because of the accumulation of lot of fat, liver size is much more. Typically, we see the fat here ballooning of the liver cells, hepatocytes, there is fibrosis, there are inflammatory cells all over. You see the white vacuolated fat cells, hepatocytes interspersed with the inflammatory cells, the black ones here and there, and these are called the Mallory bodies, the hyaline deposits of these cells. The Mallory bodies are also characteristic of inflammation and fibrosis, which is nothing but NASH. The next slide will show the final stage or the stage of cirrhosis of liver, which is nothing but the end stage disease of fatty liver, the NASH, progressing on to cirrhosis. This slide is the cirrhosis of the liver. You see the liver has shrunk, the size of the liver has reduced, and the weight of the liver also comes down. There is tremendous fibrosis, nodularity, and you can see irregular nodularity of the liver, diffuse. Some nodules are big, some nodules are small, and this liver is a shrunken cirrhotic liver. What happens is, when the liver is shrunk, there will be no scope for the blood from the portal circulation to enter. Because of fibrosis of the liver, the portal blood vessels also are constricted, so much so portal hypertension develops. When there is portal hypertension, there will be splenomegaly, there will be ascites, there will be collateral veins, there will be esophageal varices, there will be portocaval systemic manifestations of mixing of the portal blood into the systemic blood, and all the toxins entering into the systemic circulation. Now, this is the picture, histological picture of cirrhosis of liver. You can see these are the fibrous bands, the green ones are the fibrous bands of the liver, the red ones are the nodules, the cirrhosed fibrotic nodular liver with interspersed fibrotic bands, very characteristic of cirrhosis of liver. About 2/3 of the cases of cryptogenic cirrhosis of liver are due to fatty liver progressing on to NASH, then going on to cirrhosis. We don't want patients to go into this state, and we would like to pick them up at the stage of NAFLD or NASH. That is all is the story in this particular CME, the emphasis. But nonetheless, we will see some more slides about the biopsy, how to score the biopsy information, and then the histopathological information in the subsequent slides. What is the role of liver biopsy in NASH? This is the most accurate method to diagnose and stage the liver damage. It may convince the patient of the need for lifetime change in his lifestyle. NAFLD and NASH generally carry good prognosis. Once the patient develops cirrhosis, the prognosis is bad. Key risk factors are addressed and they can be treated without a biopsy. Lack of effective therapy, cost of biopsy, and risk associated with it will prevent us from doing biopsy for every patient. If cirrhosis is clinically suspected, biopsy may be needed. If you are suspecting only fatty liver and NASH, Mayo score almost replaces the need for biopsy. We have seen about the Mayo score in the previous slides already. Based on the histopathology, NAFLD activity score or NAS is developed. The markers of steatosis, the markers of inflammation, and the marker of ballooning. Less than 5% fat, 5 to 33% fat, 33 to 66% fat, more than 66% fat. The score given is 0, 1, 2, and 3 depending on the extent of fat deposited in the liver. Depending on the inflammation, no foci of inflammation, score 0, less than 2 foci of inflammation for 200x magnification, score is 1, 2 to 4 foci, score is 2, more than 4 foci of inflammation, the score given is 3. For ballooning, if there is no ballooning of the hepatocyte, score is 0, few cells only are showing ballooning 1, almost all the cells are showing ballooning, prominent ballooning is seen, score 2. Depending on these physiological changes, the scores 0, 1, 2, 3 are given for steatosis, 0, 1, 2, 3 for inflammation, 0, 1 and 2 for ballooning, and the summary score is arrived at for the interpretation, which we will see in the next slide. If the NASH score does develop depending on the histological changes that I have explained in the previous slide, based on the liver biopsy, if the score is less than 2 or equal to 2, then there is no NASH in that particular patient. If the score is 3 or 4, it is probably NASH. If the score is 5 or more, then the presence of NASH is confirmed. So, this is how the NASH score is useful in grading the patient whether he has NASH or probable NASH or no NASH at all. So, with this we come to an end about the histopathology and the clinical part of presentation of NASH. Now, the most important part is how do we manage these patients and what are the treatment options like, which we will see in the subsequent section.